Hey everyone, today I will be continuing with the playlist saying magnifying heart, which includes all the topics which are related to cardiology. So let's begin with the topic called mitral regurgitation. I have several videos in the magnifying heart, including study of the myocardial infarction, aortic regurgitation, study of the pulmonary embolism, which should increase your depth and knowledge regarding these topics. Okay, so we'll start with mitral regurgitation. Now, uh, mitral regurgitation is something which is causing the regurgitant or the flow of the blood back into that of the left atrium, and that is mostly because of the mitral wall dysfunction, or there is a flappy wall, mitral wall. Okay, so what are the causes for that of the mitral regurgitation? Now, it could be actually a leaflet pathology, which will be like mitral valve prolapse or infective endocarditis or any rheumatic heart diseases. There could be an annulus pathology as well that includes a left ventricle when it is a dilated left ventricle, or whenever there is a dilated left atrium. So imagine this is being the heart, and this is the ventricle, and this is the atrium. So if the heart, say the left atrium is dilated, so that will cause the mitral wall to stretch down. Okay, then we have the left ventricle also that would be dilated. Okay, so then we have mitral annular calcification that is mostly seen in case of females and obese and old age group. Okay, so Hurler's disease, Marfan's disease, like that. While coming to that of a cauda tendineae problem, cauda tendineae is something which is the holding of the valve to that of the ventricle. So that is mitral valve prolapse again, infective endocarditis, or any traumatic cause of cauda tendineae, and a rheumatic cause also. Papillary muscle dysfunction. Again, whenever there is a coronary artery disease or say acute myocardial infarction, there could be a papillary muscle dysfunction. Again, this holding problem is something which is the creating a problem to the valve. Okay, so left ventricle myocardium, that is the left ventricle dysfunction is there, that can also cause problem. So these five broad causes should be known to you, so that you can just enumerate the other causes. Okay, the other thing is clinical classification. That could be divided into primary and organic one, or it could be a secondary and a functional one. Okay, so now what happens is, as there is this regurgitation, the blood is going back, so that will lead to dilatation of the left atrium. Okay, and whenever there is a left atrial dilatation, we know that there could be atrial fibrillation. Because there is a atrial dilatation, there would be a thrombus also that could be also formed in this. Okay, and then we have the left ventricle which is also dilated, so that can be because of the dilated cardiomyopathy and causing mitral regurgitation, as well as aortic regurgitation can be one of the cause for the can be caused because of the dilatation of the ventricle. Then the next thing is the Carpenter's classification. So this is very important. This can be asked in the PG exams, or it could be SS exams, super specialty exams. So type 1, that is a normal leaflet motion. Type 2 is increased in the leaflet motion. Type 3 is restricted opening. Type 4 is the restricted closure. Okay, so the mitral regurgitation has been divided into acute and a chronic form. Okay, so now if we are talking about the hemodynamics, how does it work? Okay, so afterload. Afterload means whatever the blood has been into the aorta, through the aorta, whatever the blood is there, that is called as the afterload. So whenever there is the afterload, okay, and so now this blood is going into the aorta. Okay, so that is the resistance against which the ventricle eject, that is the afterload. Okay, so now say if there is increase in the afterload, that means that the blood is being ejected out into the ventricle and it is not going into the mitral valve and to the left atrium, then this will decrease the MR. Remember that. So this is going over here compensating, so there is no increase in the blood to the ventricle from the ventricle to the left atrium, and that's why the afterload, whenever it is increasing, so we have to medically treatment, in the medical treatment we have to decrease the afterload. Okay, so whatever the pressure in the left atrium is low as compared to, and the blood goes into the left atrium during the ventricular ejection. Okay, so due to the mitral regurgitation, pressure in the aorta need to be decreased so that the blood will move into the aorta. Okay, so now whenever there is the afterload which is actually there, so if this there is increase in the water, the blood is going into the left, into the aorta, so this will decrease the MR. Okay, so we have to decrease the afterload. Okay, so remember that it is afterload is nothing but it is the resistance against which the ventricle eject. Okay, the next thing is whatever we are using as a medical treatment is the dilators, vasodilators like AC inhibitors, ARBs, okay, angiotensin receptor blocker, or we have the nitroprusside. Okay, now coming to the hypertension. Now again the same applies. Okay, hypertension, BP is say 220 by 120. So will the blood be ejected into it? No, the aorta will not be carrying the blood. So what will happen? All the blood will go over here. So we do not want that. So if there is a hypertension, more blood will move into the left atrium due to the resistance in the aorta. So this is systemic hypertension, and then we have this hypertension increases the MR. Okay. The next thing is post MVR, that is the post mitral valve relapse. Now, replacement, sorry, mitral valve replacement. Now, what happens is, now you will say that after the replacement, the patient should be all right. It should be, the patient should not have any symptoms. It should be all, everything should be good. But it is not the case, because the heart was the, that was earlier, was now comfortable ejecting the into the aorta as well as into the atrium. Okay, so this is the heart. It is ejecting into the aorta as well as ejecting into the left atrium. Okay, and that the patient, the heart has acclimatized, right? It is now being comfortable now. He's thinking that this is my job now. Okay, so now whenever there is a replacement of the mitral valve, what happens is sudden stoppage of the blood to move into the atrium, and the blood was comfortable to move into the left atrium. So what will happen? Sudden stoppage is there. Okay, now what will happen here? Much of the blood is there now, that he is not aware, or that he is not comfortable with. Okay, so the LV fails. And there is a hypotension, and thus there will be a back pressure. So you know that whenever there is this increase in the pressure, that is from the left atrium into the left atrium, so left atrium we have pulmonary veins, and that will go into that of the pulmonary artery, so there will be pulmonary edema, right? So in case of acute MR, there is increase in LA pressure, so there is increase in the pulmonary venous pressure, and thus there is pulmonary edema. Okay, so there would be a hypotension and shock that can lead to decrease in the stroke volume. That is because of the decrease in the stroke volume. When it comes to the chronic MR, what happens is there is this LA dilates slowly. So there won't be such thing like the pulmonary edema, breathlessness like that. Okay, so this is important. Now, remember, what happens is there is a mitral regurgitation. We have increase in the ejection. Okay, so what happens is there is ejection fraction will be increased. This is spuriously high. Okay, remember this. This is spuriously high. So we call it pseudo high EF. Okay, pseudo high EF. Okay, so in case of the acute mitral regurgitation, there is decrease in the stroke volume, and that will be causing hypotension and cardiogenic shock. Okay, and there is increase in the LA pressure acutely, so that will lead to pulmonary edema, which will lead to PND, which will lead to breathlessness, dyspnea, and all that stuff. Now, in case of the MR, there is increase in the V wave. V wave is nothing but ventricular, that whenever there is ventricular contraction is there. Okay, so I will suggest you to go into the JVP video which I have uploaded earlier, and so that you can have a detailed discussion on the JVP. Okay, so we have pulmonary hypertension in MR as well. So why is there pulmonary hypertension? Now this is mostly because of the fact that there is a back pressure that is being created, causing pulmonary edema. So there is increase in the pulmonary artery pressure, and that is actually causing right ventricular pressure being increased. And this increase in the right atrial pressure will lead to hepatomegaly, pedal edema, ascites, and JVP. Okay, so first there is increase in the left atrial pressure, then again there is increase in the right atrial pressure. So there we have the left heart failure as well as right heart failure symptoms. But when it comes to a chronic compensated MR, so what we expect? We expect the LA dilates over a period. Okay, so there won't be any symptoms like breathlessness. Okay, so there is no breathlessness. This is important you to remember, because the question may be saying that there is breathlessness. You have to rule out chronic MR in this patient. Mainly presents with fatigue and palpitation. Okay, so the LI compliance is good. LV function is also good over here, and rarely there is pulmonary hypertension. Okay, unlike the acute MR. Okay, when I'm talking about decompensated MR, so decompensated, that means whole lot of symptoms. So left ventricle failure, increase in the LA pressure, so there will be dyspnea, palpitation, fatigue, as well as right atrial pressures are increasing. So right heart symptoms, pedal edema, ascites. Okay, and V wave is of course increased. So there are certain stages of chronic MR. So A, B, C, D. A is at risk. Then we have progressive MR. Then there is an asymptomatic severe MR. And there is a symptomatic severe MR. Okay. Physical findings, what do we find now? We have this collapsing pulse in case of the AR, right? But here there will be a pseudo collapsing as there is increase in the ejection fraction over here also. Okay, it will behave like hyperdynamic situation. So there is a rapid upstroke, okay, ill sustained peak, okay, rapid downstroke, and there is a peak is actually normal. When it comes to cardiomegaly, there would be cardiomegaly in hyperdynamic apex. This is a volume problem, volume overload state. So there will be hyperdynamic apex, okay, and there will be a cardiomegaly in this. Okay, now there is a left parasternal heave, okay, that is we get the left parasternal heave in many situations, including that of the right ventricular hypertrophy whenever there is a right ventricular hypertrophy. Okay, so that is mostly because of the right ventricular pressure overload. When we talk about S1 and severe MR, there would be loud S1, but if it is a rheumatic or ischemic cause, then it is actually a soft S1. S2, it would be wide split S2, okay, and S3 will be increased. S3 sound would be heard because of increase in the ventricular filling. Okay. Now, S3 is always associated with mid-diastolic murmur. S4 is never seen in case of the chronic MR. Okay, when it comes to a systolic murmur, that is a pansystolic murmur, which is of high pitched at the apex. Okay, so it is a high pitch, it is a soft blowing, it is best heard in the diaphragm with the help of the diaphragm in the left lateral position and at the height of the expiration. This is important. Okay, which is radiating to the axilla and inferior angle of the scapula. Pansystolic murmur is there, which can be seen in TR, MR, and in case of the VST. Okay. So now, when it comes to the jet, now jet is directed towards the lateral aspect of the atria, so it is better heard towards the axilla. Jet is towards the interatrial septum, then it is best heard toward the base. Okay. So now coming to the dynamic auscultation. So we all know that MVP and HOCM, they have the same type of dynamic auscultation. Okay, so whenever there is increase in the afterload, it increases the MR. We have already seen that afterload, whenever it is increased because of a hand grip, okay, it is increased. And phenylephrine is causing arterial vasoconstriction, that also increases the afterload. Decrease in the afterload decreases the MR. Okay, so nitroglyceride has to be given, or we can go with ACE inhibitors, ARBs, like that. And Valsalva decreases the MR. Valsalva decreases all the murmurs. Okay, exception is there MVP and HOCM. Okay, so coming to the clinical severity. Now, how do we know that this patient is severe, having severe MR? So it is because of the cardiomegaly, apex being displaced, hyperdynamic situation, okay, wide split S2, mid-diastolic murmur, S3, pulmonary hypertension. Okay, so they can give us certain idea that this is something which is a very severe one. Okay, now in the ECG, what do we expect? We expect a left atrial enlargement and we expect an LVH. Okay, and the chest X-ray, we can have a dilated left ventricle and left atrial depending upon the whatever the stage is. Okay, when it is a RVH, the apex is outward. When it is an LVH, the apex is down and outward. Okay, so this is important. Then this is very unique, that is unilateral pulmonary edema that can be seen because of in MR because of the regurgitation jet directed to the orifice of an upper lobe pulmonary vein. Okay, so now pseudo high EF is seen in case of the MR. So MR jet area, depending upon that, we have mild, moderate, severe. So 20%, 20 to 40%, 40%, that is the percentage of the left atrial area, whatever it is involved. And the less than 4, 4 to 8, and more than 8 centimeter square area, whatever the area has been involved, according to that, we have divided. Okay, so this is a bit a high fun do, but if you see vena contracta, that is more than 0.7 is considered to be severe. In case of AR, it is more than 0.6. Okay, regurgitant volume is same for MR and AR, that is more than equal to 60. Okay, so coming to the treatment part, medical therapy, there is no role because it will just decrease the symptoms, but the symptoms will recur if the valve is not being operated. So most of the cases, we have to treat the hypertension, whatever the cases. Surgical treatment like MV, mitral valve repair or mitral valve replacement or mitral clip, that can be used. Now, the indications for the surgery include, that is chronic severe MR, obviously a decompensated one we cannot leave, right? And if the patient is an asymptomatic, but the ejection fraction is say 30 to 60%, in the symptomatic cases, it is a severe MR, right? Symptomatic MR is a severe MR, okay? So symptomatic MS is a severe MS, symptomatic AR is a severe MR, and symptomatic MR is a severe MR. Okay, so you have to treat the patient. Okay, while awaiting for the surgery, of course, we have to see if the ARBs can be tried. And when it is a secondary, that means because of the certain causes, that is including that of left ventricle dysfunction, including MI and coronary artery disease. So that can be managed through as a HFrEF management itself. And annuloplasty, again mitral valve repair, replacement, and mitral clip could be used. Okay, so after the MI, we have seen that on the third day, patient suddenly goes into the pulmonary edema. Okay, we lyse the patient and the MI after the MI occurrence, and then on the third day, the patient suffers with pulmonary edema. So it is one of the rare cause for that of the MR. So that is mostly because of the papillary muscle dysfunction. This is one of the MCQ, and it is more prone to damage. Okay, so EF is, when we do a 2D echo, EF is more than 70%. So do not be fooled because of this. Okay, what are the causes for the acute MR? So this is also very important. Endocarditis is one of the cause. MI we have already talked about. Then we have the ischemic, that is because of the RWMA, regional wall motion abnormality. Iatrogenic, that is mostly after that of the balloon mitral valvotomy, and Takotsubo cardiomyopathy. These are acute causes, right? Now, symptoms of the acute MR, that is hypotension, cardiogenic shock, increase in the JVP, pedal edema, ascites, all the heart failure symptoms can be there. So now S4 is seen in case of acute MR. S4 is never seen in chronic MR. Okay. So what are the treatment options? Of course, surgery has to be one of the important thing. And after load reduction, for stabilization and preparation for the surgery, we can just go with the same ACE inhibitors, nitroprusside. And of course, mitral valve repair and replacement has to be done. So this is all for today. This was acute and chronic MR, mitral regurgitation. Thank you for watching.